My name is Adebayo Alonge. I am co-founder and CEO of RxAll Incorporated.
Welcome to the African Tech Roundup, Adebayo.
Thank you, Andile.
So what's more fun, founder or CEO?
Founder is more fun, right? CEO is more work than being a founder.
Oh, yes. So which of the two would you recommend to someone you like?
Oh, of course, be a founder. That's the more exciting phase, right? When you ideate, you build a team, you pitch, right? It's very different from being a CEO. A CEO has to do the day-to-day management, the checking of results, performance, the performance appraisals, the layoffs, the hiring. So it's more of the more tedious job.
This is just me trying to figure out what sort of personality you have. Are you the type of person for whom once your organization is at a certain stage in terms of sustainability, you might step aside and have someone else run it and maybe stay on board as maybe a chairman or something like that?
Yes, I am still discovering my entrepreneurial persona, but it looks like there's a chance I'm more 60-40 split, the way you have described.
Okay. 64 being the kind of guy to not relish the CEO side of things.
Oh, yes. I mean, I think I am more of a founder type person, ideating type person, and then running it to a certain point, and then getting an executive person to run. I mean, it doesn't mean I can do both. I can do it. I'm currently doing it, right? But in terms of preference, right, it's more on the founder side.
Yeah. Well, for people who count scholarly prestige as a thing, I'm sure looking at your CV, they wouldn't doubt that you have the chops. But I mean, there's often a lot more to it than that. Nevertheless, I thought it might be fun to start with that. But in diving into your current chosen entrepreneurial pursuit, help me understand why, for good reason, multinational pharmaceuticals get a bad rap.
Yes, primarily for two reasons. The first is pricing. So, as you know, it takes easily over 2 decades to build and discover a viable drug pipeline. And this goes into sometimes billions of dollars to identify those useful molecules and bring them to market. So usually, I mean, in terms of the IP system in the Western world, it's been sort of set up to protect these companies that do all of this grunt work so they can recover their investments over a patent period. Right. And
how long are these patent periods roughly?
Usually it's between 10 to 15 years.
Okay.
Usually. And what happens there is that no sort of generics are allowed. No other type of biosimilar products are allowed during that protected period. And obviously once the patent period begins to approach its end, you usually see a lot of lobbying by pharmaceutical companies to try and keep out the generics from coming in. You see a lot of factors that come to play just to keep those price levels and returns very high. So people I mean, the masses are sort of a bit wary. They understand that these guys need to recoup the investments, but they are also sort of upset that they would go all the way to keep those levels of profitability high even after the patent period is over. Right? That's just one bit of the pricing situation. Another one is that we've also recently seen a number of sort of finance people come into the pharmaceutical space. So to take, for example, Pharma Bro Skrelly, who was recently convicted in the US. He came in, bought a company that specialized in orphan drugs being those drugs that have very few number of people, usually 100,000 patients or less who buy it a year. And so for that reason, usually they have a sort of protected status by the government. And somewhat most
because of what you said earlier, actually, presumably that the pharmaceuticals will argue we've spent all this money trying to develop this drug. However, there are only maybe 100 people on the whole planet that need it. And if you call open season on this drug, we'll never recoup our investment.
Yes, I mean, that's
the argument, right?
That is the argument, which is true, which is actually true. But the thing is that historically, at least before the financiers came into the pharma space, the idea is that those drugs are not necessarily for profit, right? It's supposed to be a social good, and many times you would have subsidies making the coverage, so at least it's not a loss to the companies who are providing that service, right? But that has recently changed in the sense that now what has happened is that the financiers actually have seen an opportunity that the prices in this space is actually artificially low just because of the social good pharma companies have tried to do. And the people who need these drugs actually need them, right? It's not, they can't decide whether or not they can do without those drugs. They need to buy those drugs or they die, right? So that inelastic demand nature of this category of drugs has drawn in financiers like Shrekley. And now what they have done is to increase those prices by 700% in the space of 6 to 12 months of the takeover. And
maximizing shareholder value and all that.
Oh yes, but at the expense of social good and the reputation of the industry. So
as someone who's been embedded in some of the world's largest pharmaceutical groups, Sanofi, Roche, and so on, give me a sense, as honestly as you can, because I'm sure you still have friends and family in that world, but give me as honestly as you can an assessment of how the actual culture of the people in the organization might not match the sort of reputation the industry has built. Are they, I'd like to imagine, and maybe I'm naive, I'd like to imagine that they're good people in these organizations who really want them to do what they're capable of doing in terms of like the greater good. Is that the case? And if so, how difficult is it for that kernel of good to sort of permeate the entire business in your experience?
That's a very tough question, but I'll try to answer it. I would say that I would answer the question from two parts. First, from my experience working within multinationals, and secondly, from my experience dealing with other multinationals as a strategy consultant and as a sort of business person seeking collaboration. So from my experience working in the industry for those multinational companies, it's been that the vast majority of the people, especially at the senior management levels, are genuinely interested in getting the medicines that are required by people to them, right? But oftentimes they usually tend to weigh in the business side, right? Because obviously their jobs, their livelihoods are dependent on the shareholders who have put them in place there. So sometimes they do tend to go forward with business practices that does not necessarily place the good of the people over the business, right? I think if there's a decision to make between doing good versus making profit, most people would go for making profit, at least at the more senior levels. But usually at the junior levels, especially when the guys come in and they are recruiting professional healthcare people who have gone to school and studied and become professional pharmacists or healthcare professionals who are then deciding that they want to go into business. They are much more green, right? They're much more, hey, I'm going in here. It's not just about me making a living. I'm also trying to do good through my professional calling, right? So that changes as they go through the promotion process into management, right? So that is how I see it, at least from my experience. Now, from outside of the industry, as a strategy consultant, as an entrepreneur trying to collaborate with the big guys, I see that there are actually two distinct groups of pharmaceutical companies. Now, there are those pharmaceutical companies that are set up and run by scientists, right? And then there are those pharmaceutical groups that historically were set up and run by scientists, but over a course of 100 years have now, the management is now being run by business people, right? For those companies that are still being run, set up by the scientists, most of them actually are in the biotech space today, right? So you'll be talking of the likes of Gilead, Vertex. Now, these guys are pioneering new approaches to using biological molecules for drug treatment, right? And many of them are really, really, really passionate about the science, right? Really, really passionate about science. Now, do compare that versus the very old pharma multinationals that are still doing primarily with very large stack of cash. They need to be able to ensure this cash is turning around properly. They need to do the takeovers, the buyouts, so that they can keep that cash moving around. Their pipelines are dwindling, right? Because pure organic chemistry is not really producing as much progress in terms of drug treatment as it used to do in the past. So they actually are now beginning to look for more takeover targets in the biological space, right? These guys are purely financiers. Most of them are purely financiers, right? It's about how do you keep this business sustainable? How do you ensure that the research team is not just doing research and wasting our money, that they're actually turning around the pipeline very quickly? How do we lay off a number of factories? How do we do mergers? You will see that over the last 3 years, there's been a lot of mergers and acquisitions.
That's definitely been a huge trend I've observed, yeah.
Exactly. And when these mergers happen, a number of the factories are shut down. The synergies are maximized, right? So it's not so much
in the pursuit of efficiencies.
Oh, yes. So that's how you would sort of analyze the industry as it is today.
That is fascinating.
Yes, it is.
That is absolutely fascinating. Now, shameless plug here. My wife, her name is Tabiso Masuku, and she's part of a team at the Health Economics and Epidemiology Research Office that falls under the WITS Health Consortium. And she's recently helped the National Department of Health in South Africa cost the impact of replacing a drug called efavirenz and with dolutegravir as the first-line antiretroviral treatment for adults in South Africa. And I have sights on this industry from the perspective of sort of public health and academic research that's done in order to help governments like that of South Africa make better decisions around, one, what kind of drugs to roll out as part of their sort of interventions and national healthcare plans, but also sort of cost in such, said interventions and rollouts. So give me a sense of how the dynamic you've described would interact with public health in this context. Well, I can't assume that you know the drugs, but I mean, in the context of drugs that might end up in public use through, public health systems, for example, how do public health systems interact with the dynamic you've described?
Oh, yes. So I'm quite aware about the two drugs you've mentioned. They are in the category of antiretroviral drugs, right? Efavirenz has for a long time been in use.
Did I even pronounce it right? Did I get it right?
Yes, you did. Efavirenz. It's one of the very first generation drugs used for as ARV, right? But it has a number of side effects. I guess that's why they're trying to do the transfer. But the thing is that going to the question that you're asking, right? It's that Many times when the public health systems interact with the pharma space, there are two contending forces, right? The one force on the public health side is that the governments, especially in Africa, are tight on cash, and so they usually want to be able to get as much bang for the buck as possible when they're negotiating, right? On the other end is that the very big multinationals, right, depending on what drug category they're dealing with, do not necessarily see Africa as the prime market, right? So usually it's not usually a two-way or sort of bilateral conversation. It's usually three-way. There would be a third party in the form of a foundation like the Bill and Melinda Gates Foundation that says, hey, you, this government, tell us exactly the total amount of drugs you need in a year. We'll cover all or a part of those costs. And then all the pharma guys have to do is to bring it in, right? So to a large extent, the public sector, at least in terms of interaction with the public sector in Africa, in terms of its interaction with the multinational pharma companies, is not necessarily a pure market play, right? Because
it's intermediated.
Exactly, it's sort of facilitated by subsidies and a number of grants. So the incentives are very, very different for the pharma companies, right? The most important thing for them is that somebody pays for those drugs at a price that makes sense, right? While they also maximize the public relations so that it appears that they are doing as much good as possible for a region of the world that is seen to be very poor. Right, so
right.
That's how I understand the interaction takes place. Now, if you took that out, if we then if we went out of the public health sector in Africa and looked into the private market, because there is a private market, and people pay.
Well, a significant one, I suppose.
Yes.
To listeners, to everyone listening to us who's not familiar with the terrain. Of course, Africa being a very large continent with many different markets and many dynamics. But by and large, in many cases, there's either a very poor sort of public health infrastructure or in some cases still none at all. In the case of one of the, in the case of sort of leading economies on the continent, you have a thriving private sector that services a fair chunk of the population, not by any means the majority of the population, but nonetheless a very lucrative, private sector business within health, public health, as it were, in operation. So yes, just to set the context before you carry on.
Yes, I mean, that's a very good context setting. Yes, there is a very large private market, at least in Nigeria, for example. Easily over 70% of the pharma transactions happen out of pocket, right? And people actually pay for those medicines. And in those private markets, especially when you're now looking at some of the more lucrative categories like oncology, right? Where people pay, they almost pay the same market prices that you would see in the US as in Africa. There are no subsidies, no sort of local arrangements to lower the prices. Right, that's when the business then gets interesting, right? You see, rather than the pharma multinationals having just a sort of fly-in, fly-out business model, they actually have a full-fledged market development presence in those countries, right? They have the management team, they have sales office, they have local distributors, they engage with the oncologists or the medical professionals. They engage with the patients. They're actually fully on the ground doing the commercial development in the space, right? So the incentives change, just sort of flip over, right? Once you move out of the public health system to the private sector, where especially in those categories that are very lucrative, right? So this is how, say, the interaction is, at least when looking at it from an African perspective.
So give me a sense of how a private citizen would interact with that dynamic. Let's assume, God forbid, I'm a cancer patient in Lagos, and my oncologist has prescribed medication. Let's assume that I'm also, in addition to medication and treatment that I'm receiving orally, I'm also maybe I'm also scheduled for regular chemo sessions, etc. So how would it play out in that context, and using that as a hypothetical case study?
Yeah, it's a very interesting case study, because we, at least at RxAll, recently did dig deep into that oncology category in Nigeria and just sort of studied how patients actually interact with the process. And it's a very, very interesting, especially in this category. It's really very interesting. It's a bit different from other categories, but it's very interesting. So I'll walk you through how it works, right? So usually what happens is that many people present late stage on this part of the world with their with the cancer situation, right? Because many times when they begin to have first of all, there are no regular health checks. People only take care of their health when they're sick, right? And then when they realize there's a persistent headache, or there's a persistent pain, say in the breast, for example, or problem with urination, this is when they then go out to seek a sort of thorough medical examination that then identifies the condition. So many times these guys have presented late stage, and by the time they present late stage, it's usually late, right? But usually, and this is just from the research we have done, usually many times the health professionals do not tell them that their condition is irreparable, right?
Right.
They do give them the hope that there's a chance they could survive, which is very slim, and they encourage them to go ahead with the chemo sessions. Now, many times, if they were sort of engaging in the public health space, these drugs would not be available, right? Because first of all, they are too expensive for the public health systems to stock and keep. And secondly, some of them require extensive management. So you need to be able to keep the temperature properly. You need to be able to store properly. And if you look at it that, say, for example, in Nigeria, many of these public health institutions don't have power, right? Even if they had a generator, it was working maybe 6 hours a day. So the sense of the pharmacy professionals is, hey, there's no point stocking this, right? And also, if you look at the sort of people, the majority of the people who are diagnosed with a condition, right, they would usually be in the low income bracket, and it's unlikely they'll be able to afford it, right? So what usually happens is that for the more higher income people who are diagnosed, who can afford it, they would most likely take two parts. The first part is that usually the oncologist will tell them where they can get the medicine, and that's directly from the multinational's distributor. So usually when the sales rep has gone on talk with the oncologist, he tells the oncologist where he can tell the patients to go to get the medicines, right? And then the patient...
So not even pharmacies, so not even, dispensing pharmacies, no? Directly from the manufacturer or the manufacturer's agent?
For the chemo drugs that are used in session, many pharmacies don't stock it. It's too expensive to stock.
Right.
Easily, any of those drugs can account for about 10% of the total inventory of an average pharmacy in Nigeria.
Wow.
Right.
Okay, so again, I suppose at this point, I'm starting to see how the scenario might be very different for something less severe, or like perhaps diabetic treatment, for example, or chronic high blood pressure and things like that.
Yes. So if it was any of the other, in fact, even if you had oncology maintenance drugs like methotrexate, for example, you can get those. Those are rather cheap. You can get them from the local pharmacy, right? But if you're doing it with the more of the drugs used for the chemo sessions, usually you would have to go to the distributor, or you would have to go to a private hospital, right? That can easily call on the supply when it's required, right? I've even seen a situation, just recently, the last 1 month, speaking with a doctor who unfortunately has his sister with, she has a brain cancer. He actually, while she was receiving treatment here in Nigeria, he actually had to import the drug from India.
Sure.
Yeah, because it was too expensive. The prices he was getting locally did not make any sense, right? He actually got it for 25% of the price he was getting.
Wow.
After importation from India.
Look, this is also true in places like Zimbabwe, for example, where I live in South Africa, but in many cases, not just for drugs, but for medical treatment as well, it's certainly cheaper and more efficient for my parents to come and have their annual checkups here and treatment here when needed. And I have an aunt who has a hip replacement surgery scheduled, but it works out cheaper to have it done in India. So it's quite interesting how these dynamics are mirrored in different African countries as well. Yeah,
I mean, I think the health system is very similar across most of the countries, and that's because we're dealing with there's a one unifier across Africa, and that is that majority of the people are too poor to cover their own healthcare expenses.
We're catching up, man. We're catching up.
Yes.
There's a nasty legacy to take into account.
That's true.
Yeah. So tell me now, this is a great segue, I think, into, your entrepreneurial pursuit in this space. Now, I've read that upwards of 30% of drugs on the African continent currently being dispensed on the continent are counterfeit. And so tell me about your work in helping to provide affordable and also quality medicines into the continent, and massaging them into our mass market.
Yes, so at RxAll's, which is a startup that I co-founded, we are primarily providing a digital platform that enables patients and pharmacists order their medicines directly from source, right? And in addition to that, we provide an authentication service through our AI spectrometer to ensure that those drugs that are getting to the retailers or to the end users are actually of the highest possible quality, right? And what we have done with this is essentially to look at the supply chain situation on the continent as it is today, right? It used to be that in the 1970s, at least in Nigeria had a viable local producing pharmaceutical industry and a very well structured industry at that. And the incidence of fake medicines was almost zero at the time. Now, we know that from the 80s, the government had to implement a number of IMF reforms that led to essentially the elimination of the middle class. And that in its turn also made business unviable or non-viable for pharmaceutical producers in the country. And so what happened was that the many of the local production companies closed up, and the multinationals moved out, and we're currently in a current situation where all of the drugs, rather than being locally produced and the supply chain being properly managed, most of the drugs are actually imported. At least over 70% of the drugs are imported currently today, most of them from India and China.
So before you carry on, and I want you to pick up exactly where you left off, but something you said has just struck a nerve. How off the cuff do you think the average professional that's eye level with you in Nigeria, how off the cuff might they be able to articulate the background or to Nigeria's current situation as you've just described it?
It's unlikely there was.
Is it common knowledge you were saying?
No. Maybe in the generation that is in their 50s now, Yes, they would know because they were young professionals and they knew how the industry was. But for the much younger generation, that's from the guys who are from 30 years down, it's unlikely they would know, right?
Right.
I got to know about this while I was at Yale, and I got into a conversation with an anthropologist from Berkeley, UC Berkeley, who had come to give a talk about the counterfeiting situation in Africa, right? And after discussing with her, going through her books, she had actually done a major research work on the continent on this, right? And so it was through my conversation with her and listening to her I realized that the current system as it is actually due to transnational trade of drugs, right? If we had, like in the US, where most of the medicines are actually produced locally, right, it's easier to manage that supply chain. It's easier to trace it. It's easier to reduce the supply chain breaches that you see for most of Africa, right? So that was a very clear understanding of where, for us, we thought that it would make sense for us to make a difference in the current situation as it is today.
That is so fascinating. You have no idea how my mind's just, lapping this up. Just this is incredible. Well, so back where I sort of asked you to pause. Let's talk about the specifics of how you go about. From what I can tell about your company, you pretty much double as alternative intermediary, almost you're positioning as a preferred intermediary between users of these drugs and the manufacturers of these drugs. On one hand, you also, it sounds like you play a role in ensuring that the quality of supply is well under control and obviously people getting the right kind of stuff at the right quality level. Then it also sounds as though you are in some respect disrupting the pharmaceutical, the pharmacy business in terms of like maybe trying to change people's habits in terms of how they would typically access a drug, either as you described from a pharmacy or directly from an agent or something like that. Have I described it correctly? Is my understanding correct? If not, set me straight.
Yes, you're right. First of all, I'll take the point you made around intermediating, or rather disintermediating the supply chain, right? Mm-hmm. And obviously also second point you made about disrupting how patients go about interacting with the pharmacy space today, right? So if we start with the disintermediation, right? Yes, the WHO and a number of agencies have said that 30 to 60% of the drugs in circulation in Africa are fake or counterfeit. In fact,
sorry, how much?
30 to 60%.
Oh my word! Okay,
yes,
it's worse than I thought.
It is worse than you thought. I mean, we had a local study done by pharmacists in Lagos some 3-4 years ago, where they were sort of assessing the quality of antimalarials. So especially this category known as artemether lumefantrine, right? And they realized that 75% of the drugs in circulation of that particular category was fake, right? So a number of categories, actually, you can see up to 90% fake, right? Because what happens is that the guys realize that there is a high demand for that item, right? And they flood the market with a fake of that item, right? But if you talk about that disintermediation, it's also that you realize that it's not uniform across all the locations. So if you went to the much more rich areas of Lagos, you probably would not find any fake medicine anywhere, right? Because those pharmacies are possibly in a chain, right? The rich people know where to go get their medicines from those highbrow pharmacies, and those highbrow pharmacies get their medicines directly from source, right? So to a large extent, the people who actually suffer from the fake medicines are usually the middle income people, right? Because for one, they are the ones who seek medical health care. They're the ones who can pay for the service, right? Usually the poor would not seek medical health care. They would go to the local herbalist or the local witch doctor, right? And it's only when they are very sick, they will then go into the formal health system. So to a large extent, the people who actually suffer are middle class people, right? And they suffer because they usually have to deal with multiple pharmacies, right? And each of those multiple pharmacies are not essentially properly regulated by
off the grid pharmacies, as it were.
Oh yeah, there are a number of off-grid pharmacies, but there are also actually formal pharmacies also that go to the open markets. Now, the open markets are usually the major source of these bad drugs, right? But these pharmacies go into the open market. They are professional people, but they go into the open market because there is a general belief that the prices in those open markets are better. And because people who come into a pharmacy usually would be thinking about, hey, this item I'm buying from you, it's $50 cheaper elsewhere. Why should I buy from you? And so there is a price competition amongst those pharmacies, and that pushes most of them out of the formal distribution system into the open markets, where unwittingly they end up getting fake drugs, which they transfer onwards to.
I think patients. A lot of Africans can relate to sort of buying fruits and vegetables off the side of the street,
yes,
as opposed to at the local sort of highbrow supermarket or whatever, because you'll get the good deal. It's quite interesting to me to hear that that dynamic might exist in Nigeria, for example, when it comes to medicine.
Oh, yes. It exists across most of West Africa. Right. This open drug markets. If you went to Ghana, you will see the same thing, right? The same way you buy.
I can. The same way I'd buy my tomatoes or bananas.
Oh, yes. That's how you would buy drugs. That's how it works.
Wow.
Right.
Wow.
So this is actually where you find most of the bad medicines in there. Right. So that's one of the situations. The other one is also that increasingly we're seeing a number of pharmacies being run on a sort of register and go basis. So usually the legislation as it is today is that you cannot run a pharmacy without a pharmacist's license. So what does that mean? It means that all pharmacies normally should be run by professional people who understand, who have sworn an oath, right, to selling only the best medicines and providing pharmaceutical care, right? But increasingly what we have seen is that because some of the brightest pharmacies realized that they could make more returns working maybe in banking or in other industries, right? They usually would...
working for pharmaceuticals.
Yes, right. So they usually would not... You would see them that they usually would have that license free, and you don't have enough community pharmacies set up, right? But what has happened is that the guys who usually do the importation, the traders essentially who do the importation of the drugs, who sell most of these drugs in the open markets, who also are thinking long term about a possible regulatory shutdown of those open markets in the future, have realized that there's a gap in the community space, in the retail space. And so they're paying very good money, very good amounts of money.
To use someone else's license?
Yes, to use a young pharmacist's license. And the young pharmacist essentially is just a front, but actually the traders are the ones running those things. And so there is no barrier between the bad drugs they bring in from importation and selling through those pharmacy outlets directly. Right.
That is until now, right?
Yes.
Until RxAll.
Yes, until RxAll has come into play.
Until RxAll.
Exactly.
So tell me now, who makes doing what you do worth your while? What is your model? How does it? So you've made a really eloquent case of painting the picture of what the need is and why even I'm sitting here grateful you guys exist on some level.
Yes.
So give me a sense of how it ends up being worth your while to exist.
Oh, yes. Firstly, is before I go into the profit piece of it, there's a social mission. So we're not just a for-profit business. As you would know from any yearly who is worth his while, usually we're we're usually thinking about the society, about light and truth, about how we can make a difference to our own corner of the world, right? So in that aspect, we have seen that fulfillment of just being able to provide high quality medicines to people who need them, and also medicines required during emergencies, right? Because sometimes you see in some locations, the guys can have been looking for the medicine for like 2-3 days. Somebody tells them about RxAll. The patient is almost gasping to death, right? And then we deliver the medicines just in time, right? Right. Just because of that information asymmetry in the market, we have sort of helped to solve that problem. And so on that social mission piece of it, I would say it's been a very good, it's been satisfactory to us on that piece of it. Now, in terms of the sustainability of the model itself, the way we work is that we identify a few number of pharmacies, right, that are professionally run. We go through their distribution system. They have the very good records of who they buy their medicines from, how they price those medicines, right? And these become our partners on the platform, right? And then what we do is to digitize, is essentially to set up those pharmacies on our platform, right? And then you as a patient, once you order, usually we would serve you from the closest pharmacy to you, and we bring the delivery directly to you in your home or in your office, right? Before it gets to you, we use our AI spectrometer to test the drug, right? To be sure that it's within the parameters. So sometimes it's not just about the fact that the drug has been directly faked. There could also be a quality issue where the manufacturer has produced a poor batch, or handling and storage processes down the line to the pharmacy has denatured or degraded the drug, right? And so we, with our authentication, our AI spectrometer, our authentication system, goes beyond just identifying and mopping up the fake drugs. It's also ensuring that what you get is good enough to consume, right? And
right.
so
is this technology, is it proprietary, or is this is it commonplace in your industry? Give me a sense.
It is proprietary.
Okay.
We are so far the only ones who have built a machine learning platform for drug authentication in the world.
Right.
Right.
Wow.
In addition, the spectrometer we have developed is also proprietary. We have built this in-house. My co-founder is a PhD graduate from Yale, from the School of Chemistry there. And together we have designed the spectrometer. It's actually 5 times cheaper than all the alternatives currently in the market today.
Wow.
Right.
And what's your co-founder's name?
Wei Liu. Wei Liu is he's Chinese American. Right. So the design of that spectrometer is proprietary. It's easily the cheapest spectrometer of its type in the market today. And
do you guys license that technology, or is it unique to you?
So currently now we are in some licensing discussions with a major multinational in Malaysia. So yes,
I was recently in Malaysia. Beautiful country.
Yes, it is. It is a very good country, very beautiful, and it's interesting that
spread the love, man. Spread the love.
Yes, and it is interesting that actually in the region where it sits in Southeast Asia, right, they also have very high levels of counterfeiting. Right.
Oh, that I definitely know. Having grown up, part of my childhood, spent part of my childhood in Southeast Asia. When at the time I lived in the Philippines with my family, you pretty much could roll up to any street side pharmacy and grab pretty much anything without a prescription.
Yes, so it's very
at the time. I'm not saying that's what it is right now, but I definitely know there's a booming in many Southeast Asian countries, there's a booming black market for medicines and a relatively loosely regulated chemists and pharmacy situation.
Yes, it's very, very similar. We have done an assessment of that market. It's very similar to Africa. And even this licensing discussion we're having with this multinational, it's the idea being that we intend to install the AI spectrometers in those pharmacies, right? And then the patients can actually do the testing. And because the testing, and this is where our device, our platform is unique, is that the testing can be monitored real time, right? So if I gave you that spectrometer in South Africa, somebody else was using it in Indonesia, somebody else was using it in Lagos, right? The manufacturer can actually see in real time the quality of his medicines in each of those countries, right? And the software platform is able to integrate the results and say, hey, in this particular location, we're seeing a number of fake medicines of your drug. We think you need to take action in this location. And that...
In a similar way to how, plane manufacturers like Airbus keep tabs on every plane they've ever created.
Exactly.
Remotely.
Exactly.
Yeah.
So this is the strength of that application on that side, on the more upstream end of the supply chain, right? We're having that conversation separately. But in Africa, RxAll is going directly to the patient, right? Because we know that the real challenge in Africa is that patients usually, there's information asymmetry about where to get good quality medicines, right? And if patients know where to get good quality medicines, they would go for it directly.
Where for you is the biggest sort of commercial opportunity for RxAll?
Yeah, the biggest commercial opportunity in terms of pure dollar play is the AI spectrometer licensing, right? Because that is global, right? We can do that globally across the world, right? Yeah. But in Africa, in terms of impact, right, the current platform we have in place, right, is the go-to approach. But beyond that is also that it's also massively scalable.
Yeah, I was going to say, like, you must have plans to roll out to the rest of the continent, or at least start out in other parts of West Africa.
Yeah, so we recently concluded the Merck Accelerator in Kenya, and this week we're actually concluding our incorporation in Kenya, and we're having a local investor who's putting a decent chunk of dollar investment into the Kenyan company. And
a Nigerian angel?
No, it's a Kenyan angel.
Nice.
Yes, so then we're also having a local partner there too as well in Nairobi, who will be working with us.
Right.
So yes, that's the plan. It's massively scalable, because if you compare in terms of the actual dollar figure of what we can make, right? The licensing is where it is. But in terms of scale, right, there's only a few number of manufacturing companies in the world, right?
Yes.
But versus if you had 1 billion Africans using this platform, right? And it gives us the opportunity to reshape the whole industry. This is the second point you made about disruption, right? To reshape the whole industry, because we know today that there's an emerging e-commerce ecosystem. But that ecosystem deals primarily with consumer products, right? We probably will be one of the first 2, 3, 4, 5 on the continent that is now bringing that digital innovation into healthcare, right?
Look, and I mean, to your point, my wife and I are early adopters relative to the rest of Africa in as far as e-commerce is concerned. And I say that not as a point of pride, really, just as a matter of reality, given how most of the continent is yet to connect. And so my wife and I buy a lot of our stuff online. And if there was one thing I wouldn't comfortably buy online yet, except perhaps from an existing sort of big brand pharmacy that I trusted, is medication. I certainly wouldn't. I'm not at the comfort level where I'd order medication from Amazon, for example, or if that's even possible. So I totally take your point in that this is the perfect time for you guys to position in shaping consumer habits or next generation consumer habits as Africa comes digital.
Yes, and in fact, this point you have made about the wariness of buying medicines online, except you're dealing with a reputable brand, is one of the reasons why we have taken the sort of marketplace approach, where we're essentially working with a number of well-known, reputable pharmacy brands, right?
Yeah. And to kind of answer the final question I wanted to, and I'll let you finish because I think you're on your way to answering what I'd like to be my final question, which is, so I understand who and what I should be wary of in terms of what's out there, given, everything we've discussed. How do I know I can trust RxAll?
Yeah, I mean, for one, I mean, there are two reasons why you can trust us. The first is that we are essentially working with your reputable pharmacy brand in the country, right? And what we're providing to you is all of the quality that brand provides to the richest segment of your society, right? We're making that commonplace. We're making that available also to the mass market, right? From the comfort of your home or your office, right? You don't have to travel 20 kilometers out of your neighborhood to go to a rich location in order to patronize the same quality that other rich citizens in your country get, right? We bring that quality directly to you. That's the first, right? The second is that the very existence of RxAll is to bring safe medicines to people, to patients. That is our existence. It's not profit, right? Profit comes after. And so we are taking that extra approach. We have an R&D team that is building out the world's first machine learning platform for drug authentication, right? We have professionals who are in country working to ensure that the pharmacy partners who are onboarded have a reliable supply chain end to end, right? And we go the extra mile to authenticate those medicines that you're buying on the platform before getting into you, right? We don't use third-party logistic partners, all right? All of this is in-house, right? So from the point of the manufacturer onto the partner pharmacy through to us and you, eventually to you, we can trace where your drugs has coming from. And so that security is assured, right? And so this is why any patient who goes to RxAll and decides to order, currently in Nigeria, very soon in Kenya, you can be sure of the high quality of the medicines that you'll be getting.
Wow. This was meant to be a half an hour conversation at most. We're pushing nearly an hour, and every minute you've given me, I've absolutely relished. All I can say is all the best to you. We'll be watching the sky for your rise, and yeah, thank you for making time to be on the African Tech Roundup, man.
It's a pleasure. Thank you, Andile, for having me.